HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
In this COVID update, Professor Stephen Foh will talk about long COVID, how to prevent long COVID, with one strategy being a COVID vaccine booster. Professor Foh, tell us about yourself.
Hi, David. I'm a rehab physician at St Vincent's Hospital. I'm also a pain physician and head of our department here. I've set up the long COVID clinic with one of my colleagues, Professor Byrne, at St Vincent's because during the COVID pandemic, we started to see people who they call the long haulers, and they were filtering into rehab. And it became clear to me that if we didn't set up a referral clinic, that there were going to be a lot of people out in the community who weren't going to be able to manage their symptoms, and a lot of GPs who needed support. And so that's my background, and that's what I've done. I've also written a book for patients using much of the resources that we use in our clinic so that they have some educational material.
Thank you, Stephen. This is an incredibly important topic for GPs. So why don't we just make sure we are all on the same page? Could you start by simple things such as definition and incidence and symptoms of this condition?
In Australia, we use the WHO definition, which is that symptoms have to persist for more than 12 weeks after the initial infection with COVID. The symptoms can fluctuate, but they must persist for at least 2 months. Secondly, this is a diagnosis of exclusion, and that the symptoms must not be explained by any other illness. So the critical aspects of here are the fact that the person must have had COVID. I know it sounds funny, but in our clinic, we've found a lot of people who actually never tested themselves. And actually, when we did some immunological testing, we found that they didn't have COVID, and in fact, they had another post-viral syndrome. There is a really important immunological test that you can do, particularly if a person's had COVID in the last 6 months, and you ask for the nucleocapsid antibody. If they've had the nucleocapsid antibody is positive, then they're likely to have had an infection. You can also ask for the spike antibody, but you have to be mindful that the spike antibody will be positive if they've been immunized. So the thing that's important is to see that they've got a nucleocapsid antibody. It remains about 80% accurate up until 6 months. So after that, it's not always accurate. So that's a way of telling whether a person's had COVID, and I think that's the first step. There are actually 6 different definitions around the world. The Centre of Disease Control has one. The NICE group in the UK have one. The US Department of Health has one. A research group called Recover have one. And they have one for adults and one for pediatrics. And of course, there's the WHO ones. You'll hear a whole variety of words meaning long COVID, including the post-acute sequelae of COVID, or PASC. And you might hear post-acute COVID syndrome, but they all actually mean long COVID. In Australia, when you think about is this a problem worth addressing, you're probably questioning about how many people might have COVID in Australia. So this has been politicised. In the Australian guidelines which correspond with the WHO guidelines, it's indicated that around about 10% of Australians who got COVID have prolonged symptoms. Early on, the Victorian government said between 1.5 and 4%, but later they ran a different survey that showed 14% of their population had it. And in Canada, they've just looked at the whole numbers, and they are over 500,000 in Canada. In Australia, we have between 500,000 and 1.2 million people who have had persistent symptoms of COVID. So the bottom line is there'll be a variety of percentages based on the definitions and also the way you count it, but there is going to be a significant number of people in the hundreds of thousands who will be suffering from this.
Well, this is a big issue, Stephen. I suspect that there might be people who are not diagnosed and suffering with it as well. Is that right?
Well, since we've stopped, collecting data on it, a lot of people are taking rat tests, not recording them onto the register, and assuming that they have COVID. When people come to the clinic, we actually hope that they've had a PCR because the rat tests are not always accurate, and sometimes they're negative for the first few days and then become positive, as well as the later strains are not always picked up by the rat tests. So a PCR is still the gold standard. And if you've got a patient who you're worried about, just doing a PCR is a pretty standard treatment in general practice. I'd recommend that if anyone comes in with a cough or a cold, you're doing that both for your own safety and for your staff safety, as well as the safety of the patient.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Now, you've just mentioned some symptoms that we all know about. Stephen, what really are the common symptoms and do they occur in clusters?
There's over 220 symptoms, which is incredible because they've been recorded in such detail for the first time. However, I'll tell you about the 10 most common. So fatigue is reported by 45% of people. That's the most common. Shortness of breath is about 35% of people. Insomnia about a third, and immobility by about 22%. Anxiety and depression occurs in about 22% as well, and the cognitive impairment will occur in about 18%. Cough about 16%, pain, both chest pain and headache, in about 26%, and smell and palpitations occur in about 12%. So you're going to see a variety of those common symptoms. The symptoms can occur in clusters, and researchers in the US and UK are trying to define phenotypes. The most commonly described ones are 6 types. The first, the cluster 1, is multiple symptoms with abnormal blood tests. These tend to be the sickest people. They have abnormal D-dimers and CRP tests, and they will represent the most severe end. The second is a sort of respiratory cluster, shortness of breath, cough, and they will represent their own cluster. Quite often we see a recrudescence of childhood asthma as part of long COVID. So that's a second cluster. The third is a neurological cluster, headache, cognitive impairment, sometimes tremor, poor sleep, and sleep apnea occurs within this group. The fourth is a cardiovascular cluster. So you'll get palpitations and sometimes blood clots. And we've seen a number of small clots through VQ scans as opposed to CTPA scans in our clinics. The fifth is fatigue and pain being predominant. These often represent people who've had past problems with fatigue and pain and seem to have worsening of them. And finally, there are those who present with multiple symptoms but completely normal blood tests. So those are about the 6 presentations. In our clinic, we've divided people into the respiratory group who go and see our respiratory physicians, as well as the rest of us, and the other group is seen by the rehab physicians.
With such a large range of symptoms, as you said, the 6 different phenotypes, what sorts of investigations should be performed? Firstly, by GPs, and what special investigations might need to be performed by specialists?
So in general practice, I remember, the most important thing that you do is rule out really serious things. So you need to look for red flags, such as an acute confusional state, new weakness or loss of sensation, any speech abnormality. And you need to see that as that could be occurring in the context of long COVID, because we've seen an increased number of strokes and also cognitive impairment and implication of the brain. The other thing you need to check on is palpitations or severe worsening in shortness of breath or syncope and chest pain, because the other thing you need to exclude is cardiovascular disease and acute secondary infections in the chest. Once you've excluded those, then you need to run the usual tests. In our clinic, we recommend that the general practitioners do the following. That's a good old-fashioned chest X-ray, and then routine blood films, full blood count, UECs, LFTs, calcium, magnesium, phosphate, and liver function. We look for uric acid sometimes, particularly in pain syndromes, but probably most important is the D-dimer. If that stays quite high, when we're on the lookout for small clots. A coagulation profile is also recommended. Troponin to exclude any acute cardiovascular events. We also look at CK, see if there's any myositis, and CRP. CRP seems to be one of the most important features regarding prognosis. We do ask for lung function tests. If you're lucky enough to be able to do a complex lung function test, that would be great, but good old-fashioned spirometry would be terrific. So I think those are the basic tests. If you go and see a respiratory physician for ongoing problems, they will likely do a VQ scan. The importance of that is for small clots that aren't going to be picked up in the CTPA, and it's not uncommon that we find those. The second thing we look at is often a high-resolution CT, just to make sure that there isn't ongoing collapse or fibrosis. Particularly people who've been in hospital can have fibrotic changes in the base or the apices, depending if they were in ICU for a while, and that can reduce their ability to exchange oxygen, etc. The people with palpitations obviously need a Holter monitor, and we often send them for a tilt table test. This is what the cardiologists do. There is a simple test you can do in your rooms called the lean test, which is just recording blood pressure and pulse rate in different positions over about 10 minutes. It takes a while, but in our clinic, we've trained our nurses to do it, and the nurses can do it, and it's quite a good measure of postural tachycardia, which we see a fair bit. Of course, anyone with chest pain needs to have an ECG, and pulse oximetry, particularly on lying and standing, is important. We also, in looking at POTS, we also expect there to be a pulse rate over 100 on standing, or at least a 20-point difference between lying and standing. For neurologists who work in our clinic, we do standard cognitive testing, RUDAS, MOCA, MMSE. Sometimes this is surprising because you've got young people with low scores. Then we'll often go on to do an MRI, and we look for the MRI brain in particular. We're looking at spectroscopy. We often find small high-intensity signals in the frontal lobes and also around the hippocampi. And that gives us an idea about whether the blood-brain barrier has been broken down. Interestingly, in the ADAPT study, we found that the cognitive impairment closely matched abnormalities in smell, and the other thing it closely matched was cognitive testing. So when the patient said, I'm not thinking straight, they actually don't do well in the tests, and we did find these abnormal signals. So I think in terms of the gastroenterology, it's interesting that that's still being worked up. Some people are studying the microbiome, and that's quite costly. So you'll have gastroenterologists trying to rule out other causes of diarrhea or vomiting, or they'll be putting people on probiotics or prebiotics for a period of time. And only rarely have we seen people being colonoscoped or endoscoped.
Now, what do we do with regards to patients who are significantly symptomatic in terms of referral pathways? Is it the same in every state in Australia?
Yeah, great question. It's variable in every state of Australia. We looked at a recent study has been produced looking at all the different long COVID clinics. Many of them are run by Allied Health. There's more in Victoria than any other state, and that makes sense because they sort of got the lion's share of COVID. Only one of them, to my understanding, ours is a multidisciplinary specialist clinic at St Vincent's, but many are being run in general practice, and they're being run with general practitioners being the sort of medical gatekeepers and then attaching themselves to an allied health team. And that is a very good model. Not for everyone, because you need to have a bit of infrastructure, but if you can do it, it's ideal. So I think the major approach that general practitioners need to make is firstly to exclude diseases. Now, this might mean that if someone's got a chronic lung condition that you refer them to their respiratory physician to exclude it. It's possible that you wouldn't feel confident enough to do it yourself. However, some particularly rural general practitioners where access to specialist practice is more limited, they might be comfortable in doing the complex lung function tests and the complex respiratory CTs and images and trials with anti-asthma medications. And that'd be a reasonable first step. So the general practitioners really have to rule that out. Now, I know that will take a bit of time, but it doesn't exclude you from starting rehabilitation.
Can you explain what rehabilitation looks like, Stephen?
Yeah. So generally, people will have a handful of problems. Mostly, they will come to you and say, I'm having trouble working, or I can't stay awake during the day to do my usual activities, or I'm not being able to meet my family responsibilities. So they're actually going to come to you with issues to do with function. And while you're working it out, the federal government has agreed for you to recognise long COVID as a chronic disease, which means you don't have to wait 6 months to charge Medicare item numbers attached to chronic diseases. You can start doing that earlier. So it means that you can activate a mental health management plan or an extended, I think they're called extended care plans, so that you can get access to allied health. If a person's got a problem with pacing, so they're fatigued, but they don't know how to slow themselves down, referral to a physio or an occupational therapist or a psychologist would be relevant. If people are having respiratory problems, shortness of breath, or difficulty breathing with exercise, then it's reasonable to refer them to an allied health therapist, probably a physio, but it could be an OT or an exercise physiologist. It's important that those people understand the concept of post-exertional malaise. This is why many of us who saw patients with chronic fatigue early on develop problems, because the allied health people just saw this as a deconditioning problem and you just need to push them and exercise them. But in fact, you actually have to pace the exercise to their level of function. Not everyone with long COVID has post-exertional malaise or exacerbation of symptoms. And in fact, the difference between the people with long COVID and post-exertional exacerbation of symptoms and chronic fatigue ME patients is that long COVID patients don't all have post-exertional malaise, and the post-exertional malaise they do have improves. Whereas with chronic fatigue syndrome and ME, they all have to have it. That's part of the definition, and it doesn't always improve. It sort of stays the same. And so you need that the allied health people, your physio or exercise physiologist or occupational therapist, is aware of that and is teaching them how to pace their activities. So you can start with those two things. You can also call work, which I wanted to talk about a bit later, David, maybe another time. But you can call work and make them aware that long COVID has a long trajectory, and people are not going to return to work after 2 weeks of sick leave. It's going to take weeks, maybe a couple of months, maybe 6 months. So the employer has to be aware that this is a slow return to work, and they have to understand that they need to provide work from home if possible, or changes in conditions to work so that people can keep working at that level. Work is a major issue, and in a paper that was just recently produced in the Medical Journal of Australia, the UNSW group indicated that about $9.6 billion have been lost by people being unable to return to work. It represents 0.5% of our GDP, and whilst it's getting a bit less, it continues. And these are figures that are projected out from 22 to 24. So people are mostly going to be not able to work, and so contacting the employer early is a great first step.
I actually want to hop in here, Stephen, and say that now that you've mentioned work and you said you'll speak to it later, it's an incredibly important issue, but most GPs wouldn't know what to say to work and how to make them aware of it. What is your process and what do you say?
So firstly, I completely understand that. In general practice, it's very difficult to be able to do those vocational issues. There's two things to consider. One is if a person has caught COVID at work and is covered by workers' comp, and that'll happen to teachers, healthcare workers, and even we see it in manual workers sometimes who are told to go to work despite them having somebody else on the workplace having infections. So if you've got the access to workers' compensation, then you should contact a vocational rehab provider. There's a whole list of them. If you just type that into Google, you'll get one closest to you. And their job is to actually work between you and the employer. So that's one category. In the other category where people are getting it at home or not at work, then the occupational therapist that might be in your suburb will be able to give you advice on return to work and also be able to contact the workplace. But there is evidence that if you simply make a phone call to the HR department of their workplace with the patient in the room, so that there's no question of privacy being breached, and you make them aware that you're investigating long COVID and they may take longer to return to work than 3 or 4 weeks, that is a safe and easy thing to do. That will take a lot of pressure. I can't tell you how many people walk out of our clinic with simply the reassurance that they're not going to be lost at work or they're not going to lose work, and it's an easy thing to do.
Any particular paperwork you have to attend to set this process in train when it is just not a workers' comp?
I would just write a standard letter saying that you're investigating them for long COVID and you'll be happy to keep them up to date. They'll write to you if they need other advice. But often a note either emailed to the patient or so the patient can use it, or emailed to the workplace with the patient's awareness is probably okay. The other thing is that the occupational therapist can break down their work tasks and say, okay, you can do that from work, or you don't need to do all of that on one day. You can do that once a week, or speak to the HR department and say, could they have, instead of having all their lunch, for 2 hours in the middle of the day, can they have 20 minutes every 2 hours for breaks? And you can probably work things like that through.
Great ideas.
One trick, I would say, it's a little trick, but it's, I think, very helpful. What employers want is they want to know that you're going to regularly review the patients with the aim of increasing their hours at work. So in any letter you write, you say they will be reviewed regarding increasing their hours at work or regarding progress of their return to work plan. And that will make the employers a bit calmer.
Do you just play it by ear with regards to how much you increase and how quickly?
Generally, I try not to increase things without the patient's agreement. And 2 to 4 weeks every 2 weeks is pretty quick. 4 weeks to 6 weeks, 4 weeks is about right. 6 weeks is a bit slow. So I think if you work in those sort of categories, you should be all right.
There are lots of questions I need to ask you about why do people get these sorts of illnesses and what sorts of risk factors put them at risk. Maybe we can address this, and then Professor Fawkes, I think we might think about doing a second episode with regards to how you manage them. So why don't we go to the first question? Why do people get long COVID?
Okay, so the answer is we don't know. We're working furiously all over the world to try and find out. There are 5 main theories. The first is that it's an immune dysregulation theory. The immune system seems to be acting as if the virus is still moving around the body. And some of this is supported by virus reservoirs in different organs that were found in autopsies where people had died when they were overcome by the virus. They found the virus living in in little reservoirs in all the different organs. So it's possible that the immune system is still responding to those. The second is the microclot theory, which is that the stickiness of the blood has increased, and that's because of an endothelialitis. So there's an autoimmune response against one's own endothelia, which changes the flow dynamics of vessels, which lead to clots. And we found them in all tissues. So I remember early on we had one case where we were about to put in a central line through the jugular for a patient in ID, and we in ICU, and we found that they actually had a clot already in that jugular vein that we didn't know about. And so there was, and there's a lot of times we find very small clots in the periphery of the lungs, and also we found small clots in the brain. So that can occur in any organ. There's an autoimmune theory that long COVID might be due to high levels of antibody targeting normal organs, such as the lining of the gut, the blood-brain barrier, and also the endothelial vessels. Fourth theory is a neuroinflammatory, and this is based on studies showing that people who died of COVID in their autopsy, all their nerves, particularly the vagus nerve, was teeming with the virus. So we think that the virus has a predilection for the neurological system, and that's one of the reasons we lose smell and taste, because those nerves are much more accessible to the outside. And so this results in inflammation in the brain, misfiring of nerves, poor concentration, and actually affects heart rate as well as pain levels. And finally, the microbiome theory, which is very interesting, where the COVID infection causes an imbalance in the gut flora, leading to changes in the ability to absorb certain proteins. And one of the proteins is L-tryptophan, which is the sort of building block of serotonin, and also kynurenine, which are two hormone. Well, serotonin, I don't need to tell you about it, affects mood and cognition, but kynurenine is the one that we've discovered is abnormal in the brains of long COVID patients. So there's a lot of work going on in the microbiome, and I think there'll be a lot more tests of people's stool soon to have a look at that. So those are the sort of theories. With respect to the risk factors, or people who are at most risk, interestingly, being female seems to be a risk factor, and there is a theory as to why that is, which I can explain later. Being older or middle age. So the most common ages that we see in our clinic is between 35 and 69. So it's not the elderly. And one of the reasons is I think the elderly have often comorbidities that can explain a lot of their symptomatology, but we're actually seeing working age people mostly. Coming from a lower socioeconomic group is a higher risk. A history of smoking puts you at a higher risk. Admission to a hospital or intensive care units for acute COVID puts you at higher risk. And severe COVID, when there's a lot of symptoms initially. Being bedridden with acute COVID for longer than 7 days is a risk factor. So people who just go to bed for a long time are at risk. And having obviously pre-existing chronic diseases or comorbidities, particularly high blood pressure, obesity, heart disease, asthma, or diabetes, and also a history of cancer. So all of those comorbidities put you at higher risk.
Now, I'd just like you to very quickly summarize what we've been looking at and some key messages for the GPs at this stage, and we will return in the second podcast to look at the management of patients with long COVID.
So the key messages are, don't be frightened about this. This is not a heart sink patient. This is somebody who needs some blood tests and some examinations to exclude other diseases, and they need to be referred to a physio or a psychologist early on to start a program to get themselves back to work. If you do find something wrong with them, well then great, treat it and tell the physio and OT to stop. But if you don't, you've started the treatment. I think the other key message is don't wait for rehabilitation. The government has agreed that long COVID is a chronic disease, and you can use chronic disease item numbers early. And I'd use, the mental health management plan or the extended care plan when you can. And finally, it's not going away and it's not fake. We seem to be getting more and more people who are getting COVID, and therefore there will be a proportion of people getting long COVID, and that's not stopping. And I can tell you from the cases we've seen, nobody wants not to be at work or wants not to earn money for prolonged periods. It is mostly not a somatic disorder. It is mostly a real disorder and should be treated that way. And I completely take my hat off to general practitioners who are at the front line and who will make decisions that people will depend on. And the more you can show acceptance and understanding, the closer your relationship will be with the patient and the better the therapeutic outcomes.
Professor Thor, thank you very much for this podcast. We will have a second one coming up soon.
Thank you very much. Speak to you soon.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.